Hello everyone, my name is Yoanna PENEVA. I'm a medical doctor and PhD student in public health at the Faculty of Public Health of the Medical University in Sofia, Bulgaria. It is my pleasure to present the results of my doctoral research. I entitled the presentation Beyond Traditional Cardiovascular Risk Factors, the Role of Health Literacy, Mental Health, and Medication Adherence in Primary Care, Development of the Bulgarian Heart Model. This research was conducted under the supervision of Professor Lydia Georgieva and focuses on how psychosocial and behavioral factors influence cardiovascular risk management in primary care. Based on our findings, we developed a new integrated framework, the Bulgarian Heart Model, designed specifically for cardiovascular prevention in Bulgaria. Okay, so let's start with the first slide. Why this study matters. Cardiovascular disease remains the leading cause of death worldwide. According to the World Health Organization, cardiovascular diseases are responsible for approximately 19.8 million deaths annually, accounting for nearly 1/3 of all global deaths. Bulgaria continues to have one of the highest cardiovascular mortality rates within the European Union. Despite the substantial burden, cardiovascular prevention is still largely focused on traditional biological risk factors such as hypertension, diabetes, dyslipidemia, and smoking. However, increasing evidence suggests that other factors, including health literacy, mental health, medication adherence, and lifestyle behavior, may significantly influence cardiovascular outcomes. Therefore, our study aimed to investigate where these dimensions should be incorporated into routine cardiovascular risk assessment. We conducted a cross-sectional comparative study among primary care patients in Bulgaria and Germany. A total of 862 patients are included in the analysis, and the Bulgarian group consisted of 126, while the German group included 676 patients. Several validated assessment tools were used. You can see this here. The psychological symptoms were evaluated using the PHQ score. This is a screening instrument about depression. Then the health literacy was assessed using composite health literacy score. Medication adherence was measured using a modified MAS score. And in addition, a lifestyle score was calculated to evaluate behavioral risk factors. The design allowed us to compare the two populations and explore relationships between psychosocial factors and cardiovascular risk management. The comparison of cardiovascular risk factors between Bulgarian and German patients revealed some interesting findings. German patients demonstrate a higher prevalence of diagnosed hypertension, whereas Bulgarian patients showed significantly higher rates of prediabetes and impaired glucose tolerance. For most of the remaining clinical risk factors, including dyslipidemia and type 2 diabetes, no major differences were observed. These findings suggest that the traditional clinical risk factors alone cannot fully explain differences in cardiovascular outcomes between populations. Additional psychosocial and behavioral determinants need to be considered. One of the most important findings of our study concerns mental health. Bulgarian patients reported significantly higher levels of moderate and severe psychological symptoms compared with the German patients. The difference was highly significant, with a p-value below 0.001. This suggests that psychological burden represents an important and often overlooked dimension of cardiovascular risk within Bulgarian primary care. Current prevention programs rarely include routine mental health assessment, despite growing evidence that psychological well-being influences cardiovascular outcomes and patient behavior. However, there is a burning need for integrated mental health screening into routine preventive care. We also examined the relationship between psychological symptoms and medication adherence. A statistically significant association was identified. A patient with normal psychological status demonstrated substantially better adherence to prescribed therapy, whereas those with psychological symptoms were more likely to exhibit low or moderate adherence. The association reached statistical significance with a p-value of 0.009. Importantly, even mild psychological symptoms appear to negatively influence treatment behavior. This finding highlights that mental health screening is not merely a supportive measurement, but an essential component of cardiovascular risk management. Another major finding concerns health literacy. Patients with a higher health literacy consistently demonstrate better medication adherence across the study population. The relationship was statistically significant with a p-value of 0.034. Individuals with lower health literacy are Individuals with lower health literacy often struggle to understand medical information, treatment instructions, and long-term prevention strategies. On contrast, patients with higher health literacy are better equipped to make informed decisions and to participate actively in their own care. These results indicate that improving health literacy may directly contribute to better treatment outcomes. The central contribution of this doctoral research is the development of the Bulgarian heart model. This model integrates all major findings into a structured framework for cardiovascular risk management in primary care. Traditional cardiovascular risk factors are combined with a systemic assessment of health literacy, mental health, medication adherence, and lifestyle behavior. The model incorporates Score 2 risk stratification, individualized intervention plans, and digital follow-up mechanism. Its purpose is to provide primary care physicians with a practical tool for identifying vulnerable patients earlier and improving long-term prevention outcomes. The Bulgarian heart model introduces several important innovations that distinguish it from traditional cardiovascular prevention approaches. First, the model is built upon Score 2-based risk assessment, ensuring alignment with current European cardiovascular prevention guidelines and providing a standard clinical foundation for risk stratification. Second, it incorporates routine mental health screening using PHQ-based assessment. Our findings demonstrated that psychological symptoms significantly influence medication adherence and therefore should be considered part of cardiovascular risk management. Third, the model includes structured lifestyle assessment at the point of care. This allows health professionals to identify behavioral risk factors such as smoking, physical inactivity, unhealthy nutrition, and alcohol consumption in a systemic way. Fourth, health literacy evaluation becomes a routine component of patient assessment. By identifying patients who struggle to understand health information, targeted educational interventions can be implemented early. Fifth, medication adherence is actively monitored using the modified SMART score. This enables clinicals to identify patients at risk of poor adherence and to provide individualized support before treatment failure occurs. Finally, the model emphasizes digital follow-up and communication between general practitioners, specialists, and healthcare institutions. This creates continuity of care and supports long-term cardiovascular prevention. Together, these 6 innovations transform cardiovascular prevention from a purely biological risk assessment into a comprehensive patient-centered management strategy. The findings of this study have important implications both for clinical practice and for healthcare policy. From a primary care perspective, the integration of mental health, health literacy, and medication adherence assessment may allow earlier and more accurate identification of vulnerable patients. Targeted interventions can improve adherence to treatment, strengthen patient engagement, and support more personalized prevention strategies. At the healthcare system level, our results support a shift toward prevention-oriented care models. The Bulgarian heart model also highlights that the importance of digitalization in primary care through structured follow-up systems, automated reminders, and integrated risk assessment tools. In addition, the establishment of National Cardiovascular Registry could facilitate quality monitoring, benchmarking, and continuous improvement of our cardiovascular prevention programs. Overall, these measurements may contribute to reducing cardiovascular morbidity, hospitalization, and long-term healthcare costs. In conclusion, cardiovascular prevention should extend beyond traditional biological risk factors. Our findings demonstrate that mental health significantly influences medication adherence, while health literacies represent an important determinant of treatment success. These psychological factors should be routinely incorporated in the cardiovascular prevention strategies in primary care. The Bulgarian heart model provides a practical, scalable, and evidence-based framework that may contribute to improving cardiovascular prevention in Bulgaria and potentially other healthcare systems facing similar challenges. Thank you very much for your attention. I would be happy to answer any questions.